First up is Dr. Matthew Hoffman. He's at Christiana Care, and he is the endowed chair of obstetrics and gynecology for the Christiana Care health system. So he has kindly offered to join us today on vacation. So we're very thankful to have his time today to talk a little bit about machine learning and obstetrics and sort of the nuts and bolts of how they're making this work and what they're hoping to find out. Dr. Hoffman, it is your show. Thanks.
Thanks, Ian. Thanks for the opportunity to talk. And I apologize for not having my video being able to work. So as Ian has expressed, I'm an obstetrician by training, but I've been interested in both data science and improving outcomes. Although we've published a number of different models within obstetrics, I'm going to go ahead and share with one that we're in the process of implementing and talk through some of the challenges that we're experiencing. So just so everybody has sort of a level set, one of the challenges is in obstetrics is unfortunately obstetrics often is sort of last to the table. So machine learning is a relatively new concept. We're dealing with significant levels of disparities and have historically had relatively poor prediction tools from that perspective. So most of our tools have been relegated to things that third-year medical students would know, like prior preterm birth predicts a subsequent preterm birth. And really, we noted that there was a lack of integrated models to care. Within my own institution, there became a progressive interest in obstetrics, in part because we were progressively taking on risk for the state. I practice in the state of Delaware, and currently we deliver care to about 60% of all mothers within the state. And we know that we needed to work on our costs, which were mostly driven by preterm birth. So the model that I'm going to share is our work on preterm birth. Normally I would share the model with you. Unfortunately, it's accepted for publication. That'll be shared in January. So I can only sort of skirt around a little bit of the issues in terms of what we were able to find and how we're implementing it. So when you look at prematurity, it's a bit of a broad issue and really divided up into two different categories, one of which is spontaneous preterm birth. And we know that spontaneous preterm birth can be altered by things like care management. The remaining third of it is driven predominantly by preeclampsia. And we know that things like low dose and aspirin and exercise can meaningfully alter those outcomes. So within that, what we did is we partnered with our Center for Strategic Information Management and went ahead and developed a model which used about 10,000 women. Just briefly, this is a little bit of the work that we published last year in the Lancet, showing that in fact aspirin when given early in pregnancy could in fact decrease not just the rate of preterm birth before 37 weeks, but most importantly before 34 weeks, about 1 in 4, where the majority of mortality and morbidity happens. Similarly, preeclampsia is decreased by 11%, but similarly, the risk which is greatest with early preeclampsia was reduced by 62%. And obviously the cost of low-dose aspirin through pregnancy is relatively limited. Yet when we looked at our own internal, how were we doing in terms of a system, and this is data from March of this year, what we recognize is those mothers who would be recommended for aspirin, in fact, only 1 in 5 were in fact actually getting treatment. And though this is multifactorial, what we recognize is we weren't understanding the risk and we weren't meeting patients where they are and stressing the benefits across the system. So we worked with our Center for Strategic Information Management to look at an overall AI model for preterm birth, which includes both spontaneous preterm birth as well as from preeclampsia. And we had the ability to look at about 10,000 births. We deliver about 6,000 a year. And using a model, we're using 70% of our moms to derive the model, an additional 30% to validate it. And what we use is our data warehouse. So rather than necessarily working on the fly, we've long had data warehousing. And rather than just looking at both traditional risk factors, we also concentrated on demographics, diagnosis codes, lab codes, as well as social determinants of health, as well as healthcare utilization. Using this model, what we were able to do is to derive an AUC of about 0.7, and this held true in both our derivation cohort as well as in our validation cohort. What we're now in the process of doing, and I'll just share with you in the early stages of implementing this, is we actually calculate a risk score for every mother in prenatal care. This is done at entrance to care, And then again, at 20 weeks, we're knowing that risk can change throughout the process of pregnancy. We're now at the point of discussing and thinking through how we implement this. And we have a team that's meeting bi-weekly to do this, recognizing that much of what we see is actually in terms of compliance and issues in terms of providing optimal care. We decided to concentrate on the right-hand side of the curve, looking at a risk profile of about double the American average of about 20%. This was intentionally chosen knowing the fact that we needed to trade off between positive predictive value and negative predictive value. And what we had was limited resources. What our team is doing, and again, we've been doing this for about 3 weeks now, is to look at the individual components of the score. So though our model contains 15 different risk factors, what we do is we look at those to understand where we can meaningfully change outcomes. So for the example of multiple gestations, we obviously can't change a mom from having twins, but we can look at what is her compliance with her ultrasound, how frequently is she getting to her testing that's important that we know changes outcomes. So really the idea of developing an individual patient plan for each individual patient. In terms of the risk profiles, what we have found is that a lot of this is driven by things that we've not historically recognized well, particularly obesity and chronic hypertension, which is driving about 40% of the preterm births in my system. And there we're concentrating on low dose aspirin, which has been endorsed, and combining this with the texting platform, as well as assigning each individual patient a community health worker. And these folks are then meeting with folks on an ongoing basis, ensuring compliance, understanding barriers that may exist between them in perfect compliance. And our goal is to, in fact, enroll about 20 patients per community health worker. We currently have 5 of them, so we hope to get to about 100 patients in the coming weeks. And then what we do is each week, as we go over the individual risk factors, is talk through the challenges that the community health worker has found with dealing with the individual patient. Similar to others, we're facing the question of we've invested in this model, we've developed these processes, we have community health workers, but as many of you are facing resource challenges, we're being asked the question, does this work? So I will say that because we have so many patients, we are able to select subjects at random, and that we anticipate that we'll be able to serve about a third of our population each year from that perspective. Because we do deliver so many babies each year, our system delivers about 6,000, that we hope to be able to track outcomes and talk through things like compliance with treatment, and also hopefully begin to assess, did we meaningfully affect the rate of preterm birth over the time frame that we have. Some of our early thoughts and some of the early experiences, and interested in hearing others, as we started to roll out this concept to both our providers and our patients, the idea that they are at risk or they have a number has not always felt good to them. So understanding how people interpret risk is really important. And what we found is in early discussions, although we may view things as high risk, our patients often looked at it very differently. Although we would say your risk of preterm birth is 20%, they chose to look at as my risk of not having a preterm birth is 80% from that perspective. So as we started these conversations, we started to shift from the idea of low risk to high risk from that perspective, and really thinking through how we socialize it to both our providers as well as our patients from that perspective. Similarly, we recognize that our patients were part of the challenge, but also our providers. So encouraging them to support this as part of our socialization process, knowing that we need to be able to walk the last mile with our patients and that they rely upon their providers to, in fact, endorse from that perspective. And again, so we've gone to this concept of high risk, low risk to try to address some of these thoughts. So recognizing that this was a lightning round, I'm going to go ahead and stop there, and hopefully I met the 8-minute time limit.